the attendees?
And Susan.
And Susan Wilger.
Mhm.
Okay,
And
good.
Carla Flowers was the one that told me that she had an appointment at 1:30.
Oh, okay, good. Well, if she's still interested, when we finish up this afternoon, we can let her speak then.
Perfect.
Okay. Andy, are you there too?
Yes, Mr. Chair, I'm here.
Okay, I think we'll go ahead and get started then with public comment. And the first public comment is from Kat Sanchez. Are you there, Kat? Can you get on and speak?
Thank you, Chair, for this opportunity. Thank you, Chair and committee members, for an opportunity to be virtually in conversation with you, and thank you for the informative presentations today. My name is Kat Sanchez, and I'm a policy associate with Bold Futures. We are a statewide organization by and for women and people of color and Indigenous people. 2 points to make with regards to today's presentations. First, we wholeheartedly agree with Deputy Superintendent Trujillo on a framework of occupational licensing reform that is inclusive of reform for those who are formerly incarcerated. In the past two regular... I'm sorry, yes? In the past two regular sessions, licensure reform for formerly incarcerated individuals has been introduced and has been heard in committees in both chambers. Unfortunately, though, it hasn't gotten far, but we look forward to working with legislators to remove barriers for those who want to work to be able to work in the upcoming session. I also wanted to speak on the critical need to examine which license requirements are necessary and which are not. Bold Futures was involved with the rulemaking process around lactation counseling. At first, the newly formed advisory board wanted to require that all licensed counselors seek the International Board of Certified Lactation Consultant certification. That certification takes a significant amount of time and money, and many of the requirements are not related to safety. Thankfully, though, the rulemaking process allowed for the certified lactation counselor process to be added as an option for people who are seeking licensure. And this process is significantly less expensive and less burdensome. We know that unnecessary requirements can keep low income and people of color from being able to become healthcare providers. It behooves us to review and revise those requirements that have no actual impact on health and safety and just create barriers for people wanting to work. Thank you for this opportunity to speak. Again, my name is Kat Sanchez with Bold Futures, and thank you for being open to having virtual meetings and allowing public comment.
Thank you, Kat. Was that Bold, B-O-L-D, Futures? Is that?
That is correct, sir. Bold, B-O-L-D, Futures. We were formerly known as Young Women United.
Oh, all right, good.
Thank you, sir.
Thank you, Kat. Next, we have, are you there, Susan? Susan Wilger.
Hello, everybody. Thank you, Mr. Chair and members of the committee for allowing me to speak today in public comment. And I want to thank the presenters for the great presentations that really shed light on clarifying a lot of the questions I had around certification. Once again, my name is Susan Wilger. I'm Executive Director at the Center for Health Innovation. We're New Mexico's Public Health Institute. And one of the areas we focus on is healthcare workforce development. We actually administer 2 of the state's 3 area health education centers, among doing a lot of other healthcare related work. One of our strategies is grow your own. We know that New Mexico, like the nation, faces a severe healthcare workforce shortage. And so we do believe in opening up opportunities to grow our own and also opening up those opportunities so that people who come from communities look like New Mexican populations that they serve. So I do have 4 comments. Over the past couple of years, we've been doing a lot of needs assessment and place-based healthcare workforce development. We've worked with over 16 rural counties throughout New Mexico. And there are 4 areas around certification licensing that have really come up from the communities. First is we would like to see teleclinical supervision be opened up for behavioral health professionals. There are 8 clinical licensed professionals overseen by 3 different licensing boards. And social workers right now is the only one that allows 100% of those clinical supervision hours to be done via telesupervision. There has been some waivers or relaxing of the rules since COVID, but we would really like to see that opened up for all the behavioral health clinical licensing professions. And it's my understanding that that will take legislation. The second area is on access to testing or exams, or even getting training. That since COVID, there's been certain boards where where the testing has either been delayed, either because they're still trying to figure out how to do it virtually, or they're waiting to do it in person. And so we would like, if there's any support that can be done to make sure that those exams are taking place. I personally have 2 staff people who are waiting to take their exams as a prevention specialist certification, and the exams are on hold right now. The third area is to standardize the data that is collected by the certification boards. We've spent multiple time and hours tracking what the requirements are. We're specifically interested not only in the professional licensure, but we also tracked 12 certifications or credentials that have to go through a licensing board. And it took many, many hours and many, many months to get that information. And so if there's any way that we can streamline and standardize the data that's collected, for example, is that licensure, we may have people who are licensed, but they're not actively practicing. We need to know the location where they're practicing. And then just basic information, just in terms of demographics, would be really helpful. We would like that information available to the public. Those of us who are looking at long-term structural solutions around the healthcare workforce development, we really need access to that information to know who is practicing where, so we can work with communities to plan accordingly. And finally, just streamlining, if there's any way to streamline how the requirements are presented with the 12 credentialed or paraprofessionals that we've been tracking, just even to figure out their core competencies or their testing, we had to dig through layers and layers within each of those boards. And so if there's any way that we could be helping, or we would love to see some more streamlining, because it's confusing, I think, for those pursuing those licensures, and also for employers who employ those professionals. So that's the end of my public comment. Thank you very much, everybody.
Thank you, Susan. Let me just ask you, are you actually working on possible legislation that would be introduced on some of those topics?
The main one we're looking at legislation is the teleclinical supervision for the behavioral health professionals. And I'm reaching out right now to all the licensing boards as well as the professional associations to see where they stand on that. This interim committee might be interested in endorsing that if you have, but it would have to be in a draft form that is ready for introduction. So the date we will do that is our last meeting, December, it's the 12th?
I mean, November, not December, November, November 12th
Right.
is our last meeting.
And
So if you have it ready by then, we could consider it for endorsement.
okay, yeah, and I'm shooting to have it ready by October 22nd because I will be presenting on a panel. So hopefully I'll be able to present something then.
Okay, very good.
Thank you.
Thank you. Are there any other public comments at this time? Ellen Pines, are you out there? Jim Jackson, are you out there? Don't have anything to say today. Okay. Seeing no other public comment, do we know, Andy, if our next presenters are here yet?
Mr. Chair, they're not at this time. I can reach out to them and see if they'd be amenable to starting a little early.
Okay, well, we can just wait in place until they come on. This is the physical therapy proposed compact. And the
Correct.
presenters are TJ Cantwell
Yes.
of the Commission and Janet Pop of the New Mexico chapter.
Correct.
Okay, well, we'll wait here until you let us know.
Okay, sounds good. Thank you.
Mr. Chairman, this is Linda. Mr. Chairman?
Yes, Linda.
Hi. Yesterday in the tobacco settlement, I think Chairwoman Liz Thompson was asking if anybody has any good jokes. Does anybody have a joke to pass the time?
Actually, I remembered it.
Oh, okay.
I had a joke yesterday. So why does the Finnish Navy have barcodes?
No, why?
Because they want a Scandinavian.
Oh, right.
Cute.
Very good. So you brought the subject up, Senator Lopez. Do you have any amusing tales to share with us?
I have to ask Cherish. Let me go ask her. She has some good ones.
Okay, Mr. Chairman,
Yes, Senator Padilla, you've got something.
I'm going to take a stab at the whole joke thing. Why did the duck get kicked out of the restaurant?
The duck get kicked out of the restaurant.
Why did the duck get kicked out of the restaurant?
Huh.
Because he couldn't afford his bill.
I thought it was because he wasn't wearing a mask.
That too, but he couldn't afford his bill, Mr. Chairman.
And Senator Padilla, even as you started, my granddaughter started clapping.
Wow. We're on the same page, your granddaughter and I.
Senator O'Neill, are you there? I saw he signed in.
So I'm surprised, Mr. Chairman, I haven't gotten any feedback from any senators on this call. I told that very same joke on the Senate floor earlier this year during the regular session, and you all sort of laughed and sort of booed.
Still couldn't answer it.
Mr. Chair, this isn't a joke, it's a plug for tomorrow's Disabilities Concerns Committee.
Well, good.
And I hope everyone on this committee got an agenda, and so that we can encourage more people to listen in. So we're going to have some interesting things about a guardianship program, and also disabilities during the COVID and some of the challenges that people have had. I don't have the agenda in front of me, but that's just a few of the things we're going to be talking about. So.
Oh, and Senator, Mr. Chair, I'm presenting in the afternoon on challenges in special ed through the decades. So that might be interesting to those who've been around for some of that. When you were calling out Jim and Ellen before, that I'm sure they'll be on tomorrow.
Yes, Jim is for sure. So that's great.
Good.
Thank you.
Mr. Chair,
Yes.
we have one of our speakers is on waiting, Janet Pop, and I think I'm getting a message that she may be able to start while we're waiting for TJ to join us. That's
Good.
to her and you, but I'm getting a message from Juliana that they may be able to get started.
Okay. Well, let's go ahead then with Janet Pop she's co-chair of the Education Committee for the New Mexico chapter of the American Physical Therapy Association. Are you with us, Janet?
Janet, it looks like you need to unmute.
Okay.
There we go.
I'm here. I also need to be allowed to share my screen.
It looks like you have that permission now.
Okay. It's not quite allowing me yet. It's grayed out.
Nancy, are you able to assist her?
Yes. I think this might be the same problem we had the last meeting where some were able to share their screen. Hang on one second.
Nancy, are you able to do it and advance the slides for her?
I can do that if that's okay.
Is that all right, Janet?
No, that's fine.
Okay. Thank you, Mr. Chair. I didn't mean to butt in.
No, that's great. I'm glad.
Okay. So I will just tell you when to advance your slide, and I won't sound like the soup Nazi. I'll just ask politely. So good afternoon, Chair Tizzi-Pino, Vice Chair Armstrong, and members of the committee. My name is Janet Pop, and I'm a physical therapist speaking on behalf of the American Physical Therapy Association, New Mexico. And I am expecting TJ Cantwell, who is the Compact Administrator for the National PT Compact, to be on the call, to be available to answer any questions that I may not know the answers to. But first, I'd like to recognize and thank legislators for your support in addressing consumer access. In recent years, fair copays legislation was passed in addition to the direct patient access. So we think that the compact is another step in improving access to healthcare in New Mexico. In addition, we think the compact will help to promote public safety. Importantly, it will retain state authority, state oversight. If malpractice happens in New Mexico, some action against a patient, that the licensing board for New Mexico has authority to oversee and investigate. And finally, the compact will improve licensure portability. So I'd like the next slide, please. Okay. So the physical therapy licensure compact, just as a baseline, I think many of you understand what a compact is, but a physical therapist is licensed in a state, in the state that they have their home residence in. And if they would like to practice in another state, maybe on a temporary basis, they would seek a compact privilege in that state. So they would maintain, they've gone through applying for a license in a home state to the licensing board. They've been vetted, they've been issued that license, and now they're looking to practice in another state under a privilege. So it facilitates interstate PT and PTA practice, and it helps to improve public access to physical therapy services. It's certainly a faster process than traditional licensure for eligible applicants. And so far, 28 states have adopted the physical therapy licensure compact, including the states bordering New Mexico. Next slide, please. Okay, so how can New Mexico join the compact? The first step is to adopt compact model legislation. If New Mexico joins the compact, they receive one vote on the National Compact Commission. And the delegate who represents New Mexico is typically selected by the licensing board. Another requirement is for new licensees in New Mexico that they must pass a national exam and undergo an FBI background check. And so the thinking was during the development of the compact that if there was a requirement for all existing licensees to have to go through an FBI background check and pass an additional national exam, that would be too much of a burden on the profession. So it's for new licensees, that is the requirement if you join the compact. In addition, the licensing board must require continuing competence for licensure renewal. Next slide. Okay, some of the benefits to New Mexico. So it will preserve the current state-based licensure and disciplinary system. There's flexibility for the state to set additional compact fees. So to apply for the compact, there is a $45 fee, and then any additional fees if a state decides to charge an additional fee. And those fees vary from state to state who are in the compact, from $0 to $150. So each state really has their own abilities to set what they think is right for their state. It should improve the recruitment of PTs and PTAs, particularly in rural areas. One example would be if a traveling therapist is needed to provide a short-term coverage during maternity leave. Now, a therapist who's in a compact state can quickly become licensed, obtain a privilege to come on a temporary basis to provide coverage in New Mexico. Improved access, improved choice for physical therapy care. And it also streamlines the ability for licensed PTs and PTAs to work across state lines. So, for instance, say a therapist who has home license in Texas is in a rural area and is somewhat underutilized. They could cross borders working under a privilege in New Mexico to provide service in another clinic, another healthcare center. So it may be a way to help address rural access to physical therapists and physical therapist assistants. And then there definitely is a benefit to military families. So certainly military spouses often shoulder the burden of moving their families to a new location. And at times their loved one has been deployed suddenly. So having a compact is one less duty, one less documentation collection, one less task that they may have to do to establish their licensure or to be the ability to practice in New Mexico. It's certainly a faster process. They don't have to track down transcripts and all of the other documentation. So there's improved licensure portability, and it's certainly a benefit for military families. Next slide. So we put together some frequently asked questions concerning patient safety, but questions that are often asked about the compact. And one of the main questions that's asked is, how does it affect scope of practice? So the compact does not change the scope of practice in a state. This physical therapist or the physical therapist assistant must work within the scope of practice in the state where the patient encounter takes place. So if someone has a home license in Texas and they have a privilege to work in New Mexico, and that's where the patient encounter takes place, they must follow the scope of practice in New Mexico. I mentioned the fee. The compact fee is $45, and the state can set their additional fees. The compact privilege is renewed when the home state license is renewed. So it links to the home state license. And then certainly patient safety is always a priority for everyone involved. And the compact helps with that. When applying for a compact privilege, the physical therapist or physical therapist assistant cannot have any active encumbrances or disciplinary actions against their license for a period of 2 years. And if a compact privilege is revoked in one state, it is automatically revoked in any additional states that that clinician may hold a compact privilege in. So that really helps to ensure patient safety. Next slide. Some other questions. So when the compact was under development, there was concern by some state licensing boards that therapists who were less qualified may be allowed to work within their state, which just really isn't true. The academic programs for physical therapists and physical therapist assistants are nationally accredited, and they have been for some time. New licensees must pass a standardized national exam. So there really is a high standard and a consistent standard for the therapists who are completing their programs. Another question is about the scope of practice. So how, if a therapist is coming into New Mexico under a privilege, how do they know what our scope of practice is? And so when a therapist is applying for a compact privilege, they are required to complete the jurisprudence requirement for the state. So in New Mexico, they would have to complete the jurisprudence exam, showing their understanding of our scope of practice. And that's a requirement during the application process for the privilege. And then if a state wants to adopt the compact or join the compact, they are required to link continuing competence with the license renewal process. So there are some states that still don't require continuing education, for instance, but to join the compact, that is a requirement. And just so you have a sense, in New Mexico, we have that requirement. It's 30 CEUs per 2-year renewal period. And to compare to the border compact states, you can see in the same 2-year period, Arizona requires 20 continuing education units, Colorado 30, Texas 30, and Utah 40. Next slide. Okay. And finally, there's always a concern about licensing board oversight. So how does the compact change the powers of the state licensing board? Well, the state licensing board can investigate any allegations and take action, adverse action against a compact privilege. The home state licensing board can take adverse action against the physical therapist or physical therapy assistant's home state license. So an example of that, a therapist who has a home state license in Colorado has a compact privilege in New Mexico. And something happens in New Mexico where there is some allegation related to patient care. The New Mexico board could investigate and take action against their privilege. The Colorado board would be taking action against their home state license. And finally, the commission rules only apply to the administration of the Compact Commission. They do not apply to how New Mexico handles physical therapy statutes. And we want to point out, we're excited that the Physical Therapy Licensing Board did take a position during the July 22nd meeting. So the board approved a motion to support the legislative process for New Mexico to join the Physical Therapy Compact. So we're here today hoping that this committee will consider supporting, endorsing physical therapy compact legislation, and perhaps endorsing it during your December meeting. So thank you for your time. That's my presentation. I hope that you have some questions so we can continue this discussion.
Did TJ want to say anything? Is he on?
He is, because I was sharing my screen, I couldn't move him, but there he goes now.
The committee would like to ask, sounds that Janet did a great job doing a good overview of the compact and what it is and some of the benefits of it. But I'm sure there's probably some questions from the committee that either her or I can answer for you.
Okay. Thank you for joining us. Okay, we do have some questions. So let's start with Senator Liz Stefanik, followed by Senators Linda Lopez and Antoinette Sedillo Lopez.
Thank you, Mr. Chair, and thank you to the presenters and to everyone there, and Madam Chair. I have a couple, let me just ask a couple of questions and then just hear what everybody wants to say. First of all, what the compact for the was controversial and it was not smooth sailing. So I'd like for you to discuss how you might overcome those same obstacles. And secondly, during this virus stage, there were people who were from different states who were trying to come in and help practices, in particular in physical therapy, PTs and PTAs. And could you tell me specifically how this compact would help that situation in the future? And perhaps tell me about any situations you knew about that occurred during this virus period. Thank you, Mr. Chair.
Janet, do you want me to take that, or do you have anything to say about it? Oh, okay. So this is TJ. So I would start by saying, and I think I missed part of it, but it sounded like you were talking about the difficulties with integrating the nursing compact, and that you had difficulties with that. What I would say is that, we've implemented the compact. 28 states have joined the compact so far. We've implemented the compact. That means they're activated and they are actually issuing and accepting compact privileges in 20 states already.
No, excuse me. I'm not. Excuse me. it in our bit. I'm sure you will
Senator,
come.
you're breaking up, Senator, so you might want to start over again with your comments because we missed a lot of what you were saying.
I had a series of questions. Smooth. Obstacles of how would this compact assist ETs and PTAs during a virus or a pandemic where we might need people from out of state to come in and fill holes? And thirdly, I'm asking about situations you might have heard of during this virus that this compact could have helped.
Okay, I think so. Janet, I think, is trying to say something, but is muted.
There, I'm sorry. So this is Janet Pop, Mr. Chair, Madam Vice Chair, members of the committee. So one of the ways the compact would help, if there were therapists that were needed in the state, the process of obtaining the privilege takes really minutes, which is different than, say, reciprocity. Reciprocity can be close to as long a time for receiving a license in New Mexico. The other difference with, or not a license, but the approval, the endorsement to practice in New Mexico. The other issue around that, since the licensing board may not be issuing a license as part of the endorsement, this reciprocity, they may not have the ability to take action against the endorsement. At least that's my understanding. But with the compact privilege, it's really a matter of minutes. If a therapist is in a compact state with a home license, they can, in a matter of minutes, get the privilege to then practice in New Mexico. I think that I was having trouble hearing all of the question, but did I answer that sufficiently?
Senator Stefanik?
I think, Mr. Chair, we're just going to I'll let other people go on. My question wasn't really answered, but let's just hear the other questions and discussion. Thank you.
Senator, I have a suggestion. When you come up to speak, turn your camera off. That might make it possible for apparently you have low bandwidth there. So let's go then to Senator Linda Lopez.
Thank you, Mr. Chairman. I just have a question. I think reflective of what we did with the nursing compacts. Can you hear me? Oops.
I would suggest the same thing to you, Senator. Turn your camera off while you're speaking because you've got low bandwidth too, apparently.
There's three of us trying to use it here between school and everything. So, okay. Can you hear me now? Yes? Okay. My question, Mr. Chairman, is in regards to the nursing compact that we had and we passed I think just a few years ago. There were some concerns that were raised during our debate. And of course, with these compacts, I have a concern, I think, still remaining in my thought process. If something happens in one state and they direct New Mexico to do the same, that would have an effect on what our physical therapists and others could be able to do. Because I think that was one of the questions, if I remember, Mr. Chairman, of concern as to how this independent type of commission essentially would be directing for the different entities in different states to do their work. And I know there's always the legalities and everything else that goes into the arrangements that are made, but I am concerned as to what it could do and what impact it could have. If, and we were talking about reciprocity and everything else, I understand that, but still a concern as to what authority this commission would have over the state of New Mexico. Is there anything that either one of our presenters could share with us on that? Thank you.
Mr. Chair, this is TJ Cantwell. I'm happy to answer that question. As Ms. Pop stated during her presentation, the Compact Commission does not, and is in fact limited in what it can recommend. And our rules and any of the processes that we go through are related specifically to the operation and the effective administration of the PT Compact and the Commission as a whole. It does not deal with or affect any at all the scope of practice for any one state. In fact, I can tell you that that's not something the Compact wants to get involved in, is the scope of practice and what the requirements are in order to practice as a PT or PTA in a state. We have realized that there's variances throughout the country. And in fact, the Compact allows for really the requirements of any PT or PTA practicing under Compact privilege to have to follow the scope of practice where the patient is located. And so that, guarantees that if somebody is practicing under a Compact privilege in New Mexico, they'll have to follow the New Mexico scope of practice. The Compact itself, the Commission, does not issue rules or any mandates or anything like that related to the scope of practice of a state. The furthest it goes is the requirements, as Ms. Pop mentioned, of the fact that the state must have FBI criminal background checks for initial licensure, and they must institute CEU requirement of some kind for PTs and PTAs in their state as a licensure requirement, but again, does not get into any scope of practice issues of what a PT or PTA can't do. That would still apply fully, just like a regular license. Licensee would have to follow any of the requirements of that state. So would any Compact privilege holder, and that would not be in the purview of the Commission.
And Mr. Chairman, I appreciate the description, but I still go back to this entity of a commission. For the rights, abilities, et cetera, that this commission is encompassing, what could, for those who are current members, it sounds good. But what about with the change of commissioners that sit on this particular commission, and things can change? We all know how that process works too. And Mr. Chairman, my concern is just with a caution, if New Mexico does go forward with this, what do we have to protect ourselves, and making sure that we don't have someone from the other side of the Mississippi with their, votes and such that they can bring in that then can help to direct what we try to do here in New Mexico. And the same thing from somebody here on this side of the country that would band together on votes to change and mandate and change the direction of the commission. I'm always just wary of it, Mr. Chairman. It's just a caution, not saying anything to say negative per se, but it's just a concern that I had with the nursing compact. I'm still not comfortable with what happened. Still waiting to see what the outcome of that is. And it's just the same concern that I have here. So that's all, Mr. Chairman. Thank you.
Did you want to respond to TJ or Janet?
Again, I would just, I understand the concerns. I guess I would point to the fact that the commission is a representative body of all the delegates, individual delegates from every state. That is a majority vote. That anything that would be considered by the compact is really unrelated to scope of practice. But that that in any case, what was be considered would be up to a delegate majority to determine. But the commission and our rules and our bylaws and our in the law there is also fully publicly available to see what we've done and what our limits are, just as other commissions are limited in their powers and authorities as well.
Mr. Chairman, if I could, and I apologize, one more question to add to this. Are all 50 states participating, plus our other members of the country? So that mean like for Puerto Rico, Guam and others, or is it just limited to the mainland?
We have 50, so it's the same. All the jurisdictions are eligible to join the compact, including the Puerto Rico and the Virgin Islands and the District of Columbia. So there's 53 jurisdictions that are eligible. Right now, 28 have enacted the exact same compact legislation that you would be considering.
Okay, and one more final question on that, Mr. Chairman. How many members? Is it just one member per state? Or is it more than that? How many voting members are allowed?
One voting member, one delegate per state that's selected from the physical therapy board. It can be a public member or an administrator of that board, or any member of that board, but one per state is allowed, and that's selected by the state board itself and appointed to the commission board.
Okay, thank you, Mr. Chairman.
Thank you, Senator. Next, we'll go to Senator Antoinette Sedillo-Lopez, followed by Representative Thompson.
Thank you, Mr. Chair, and thank you for that presentation on the compact. That was very interesting. Does our state, when they try to use the privilege, as you describe it, do we get notice of any disciplinary proceedings and other complaints against the person seeking to use the privilege?
Yes. So that is one of the advantages of the compact, is because you would be part of the compact. We create a centralized database of licensees and compact privilege holders. And so that if any one of those individuals that is either licensed in the state of New Mexico or has a compact privilege in the state of New Mexico ever receives a disciplinary action, it would be automatically notification would automatically go to the state board, and then vice versa. And so the information that's available, again, is much more readily available. And then those individuals, in order to even be qualified for a compact privilege, would have to go through a vetting process, which we've established, again, to make sure that they meet their criteria, that they don't have any adverse actions in the last 2 years, and they don't have any encumbrances of any kind on any licenses that they hold.
But, and I appreciate that. That sounds like a really strength of it. But when somebody initially wants to come to this state, would our board immediately get, like you said, in order to do it, they shouldn't have had a disciplinary action in the last 2 years. But let's say they had a bunch of disciplinary actions before that. Would our board be able to say, we're not comfortable with this person's history?
No, under the compact, you would not have the ability to determine that. Again, that would be more of a licensure process decision, where the board would look at each individual applicant. In the case of a commission, the compact commission, in order to get a privilege, you just have to meet those criteria. If they have previous history, again, that does not qualify, and would not disqualify them from the compact, they would still be eligible for compact privileges. And so they, again, this is still meant for the best of actors. But it looks at those people that would have had any previous disciplinary action, would, after a period of 2 years, allow them to then become eligible again, regardless if they've had 10 or 1 disciplinary action in the past. If they have, however, had any revoked licenses, so anything that's been revoked or suspended license, that would be considered an encumbrance, and therefore they would never be able to get a compact privilege, because they would not qualify. That would be considered an encumbrance, basically an ongoing encumbrance against the license somewhere else.
And would the public be aware of those older disciplinary actions?
No, they wouldn't be aware of them, just as they wouldn't be aware of them through a regular licensure process. They wouldn't know who has previous actions.
Okay. This privilege, how is the privilege different from the license? In what ways? I understand that you're making a distinction, and I'd like to compare what someone operating under a privilege compared to someone who's licensed. So
if somebody with a compact privilege, basically the equivalent of a license for the purposes of being able to practice in a state. So they would still have to follow the scope of practice and follow all the requirements and rules, the same as a regular licensee. The best way to think about it is it changes the requirements for initially getting the ability to practice in the state. So everything up to practicing, it streamlines that process. So it makes it easier for somebody to get a privilege to practice in the state if they meet those criteria without having to go through the regular licensure process. But everything following that is really the same. I guess the only other difference would be the continuing education credits. Somebody would, instead of following that individual state's continuing education units requirement, they would follow their home state license requirement. So in some senses, then they only have to worry about following their professional education with their one home state, instead of worrying about the 10 or 20 different home states that they may have to if they've got those different licenses. So it streamlines that process for them as well. And so that is a different requirement than a licensee, but most everything else is the same, except for, again, that those initial eligibility criteria in order to be licensed, and the process for which you do it. You go through the commission instead of going through a state licensing board individually. We issue the compact privileges on behalf of each state board, again, going through our online process to vet everybody.
That makes sense. Years and years ago, when I resigned from the DC, or when I went inactive with DC, that was why I'd have to comply with DC CLEs and also New Mexico CLEs, and it was too much. Is somebody who is privileged to practice in the state of New Mexico, do they also submit themselves to the jurisdiction of the state for purposes of malpractice claims?
I'm not sure if I understand that question. Could you, I guess, re-clarify what or restate what your question is?
Well, I was thinking about what Senator Ortiz-Pino said earlier about why, because the compact doesn't say anything about limiting liability for these privileged members, right? The people who have privilege. The compact doesn't say anything about that. It's silent on it.
Right. So they would be the same. I think the answer to the question is, it would be the same as a licensee. So, they would be considered the same as liability as the licensee. And so they would be known to the New Mexico board. As soon as they get a compact privilege, the New Mexico board's notified of it. They're aware of it. Again, have the same abilities to take action against any individual, just as though they were a licensee. Again, they can take action against open investigations and due process for compact privilege holders as well.
The board could do that, but let's say I was treated by a physical therapist, and for some reason, I don't think this happens a lot. I love my physical therapist, but let's just say hypothetically that there was a claim against a physical therapist who was privileged to practice. Would the state have jurisdiction over that individual if they weren't licensed here? They were only privileged to practice.
Yes, because it's legal. It would be, and that's, again, advantage of a compact is that because they would have legal standing within your state because of the law that you would pass, is that you're basically putting them underneath the umbrella of the New Mexico state law. That's where something like a reciprocity agreement or something where you're allowing other states, and some states are looking into this, just allowing anybody to practice from another state. If they're licensed in Utah, they can just come and work there and not have to do anything as far as getting approval from anybody at the state of New Mexico. That's where the problem would become, that you'd no longer have, standing to go to do anything against that individual because they actually were not permitted to practice in your state. But through a compact privilege, because it's under, compact law, they would be issued a unique compact privilege number. They would be practicing underneath the rules and requirements of the state of New Mexico, and if found to be violating those, then they would still follow under the same New Mexico state laws to deal with that.
Okay, so I was just, again, thinking about Senator Ortiz-Pino's point that the lawyers made, I guess. So let's, and maybe I'm being too theoretical about this, but let's say a physical therapist worked for a corporation that was incorporated in the state of, just randomly, Maine. and the physical therapist came to practice here, but somehow, I don't know, they practiced here, but was working for the company in Maine. The physical therapist would have individual liability, but it's possible that the Maine, that's why I chose Maine because it's so far, that the Maine company might not have the connections to New Mexico that would allow it to be sued within the state or liable to anybody within the state. It's theoretically possible. Is there anything in the compact that addresses that?
There's nothing that directly addresses that in the compact. Again, I guess I would point to the same issue if a licensee came here, whether they're practicing under a license in New Mexico, would you have that same issue in state law? The compact doesn't address it directly for compact privilege holders, especially.
Okay, because I would argue that if that company allowed their employee to come to New Mexico, that should be sufficient to subject them to the jurisdiction of the states, would be the argument. But I was just kind of exploring it. I appreciate those answers and I appreciate the presentation. Thank you, Mr. Chair.
Thank you, Senator Silvio Lopez. Next is Representative Thompson, to be followed by Representative Armstrong.
Thank you, Mr. Chair. So I think we're making this a little more complicated than it has to be. So I'm going to ask either TJ or Janet. Let's say I'm a PT in Durango. Farmington Schools needs a PT. I don't want to go. So tell me just quickly walk me through what I would have to do right now to have the privilege of working for the Farmington Schools, and then how you would do it under the compact. Let's have a compare and contrast.
Janet, do you want to take the first part about the licensee, and then I will handle the compact?
Sure. So if the therapist in Colorado wants to work in Farmington, they would apply to the New Mexico Licensing Board for a license. And there's an application process. There's a requirement. Now, it's been 9 years now since I did this, but I'm pretty sure, since I moved to New Mexico, that you have to request your transcripts from the program that you graduated from, and those transcripts get sent directly to the licensing board. So that takes some time. You have to complete the jurisprudence exam, and you have to wait for this whole process to take place. And the way the administration of the board is, they're stretched thin. So it may take 2 months to have that license issued. That's sort of my recollection of, for a license that you petition to the board. And then,
just on that point, Janet, is there a background check that would be done, or you don't have to do a background check?
So there was no my understanding and my recollection, there was no background check required until there was a rule change just this past February, where now there is a background check requirement by the licensing board. But prior to that, I remember getting a background check, but that was through my employer. I don't believe that there was a background check requirement at that time, and the rule didn't go into effect until February of this year.
And on the compact side, if someone who wanted to get a privilege to practice in New Mexico, again, presuming that New Mexico has passed the law and become active in the compact and implemented all the different rules, et cetera, that they would essentially go to our website, ptcompact.org. We have information there to learn about what you need to do for various states. In this case, for New Mexico, it would require a jurisprudence exam to be taken. They take a link, go take the jurisprudence exam for New Mexico. Once they've completed that jurisprudence exam and they've passed it, they can go into our site, they'll log in with an FSPBT ID and passcode, which they all have when they took the NPTE exam. They update their contact information. They select the states or they update their contact information, put in their driver's license information to verify home state. That our system then would automatically verify that they meet the criteria, that they have a license in a active member state for the compact. They have permanent residence in that same member state, no encumbrances in any licenses, no adverse actions for the last 2 years, and then it will ask them to attest they've completed the jurisprudence for that state, to attest that they've done so and passed it, and then they can go through, select the state that they want, and pay the fees online. And then really within less than 10 minutes, they're issued a unique compact privilege number for the state of New Mexico. New Mexico is informed by email that individual has got a compact privilege in the state. That individual gets an email as well. It's verifiable on our website instantly. And so within a matter of minutes, they have the privilege to practice in New Mexico going forward, and that will be tied to their home state license and expire whenever their home state license expires. So then they'll have to renew it at that time as well. But that process is all automatic based on the licensure information that we receive from the state, so we can verify eligibility. And so that is that is the extent of our process, which really is very much automated, and again, based on the licensure database that we have from the states that are active in the compact.
Thank you. I think that kind of clears it up. It could be 2 months versus, depending on how long it takes you to take your test, to 2 days theoretically. So I think that's an important, and I think it's important also to keep saying that if you're practicing in New Mexico, you're practicing under our laws. No matter where your license is from, when you practice in New Mexico, anything that I'm that I'm responsible for, or whatever in New Mexico, someone who comes through the compact has exactly the same qualifications, exactly the same responsibilities, and exactly the same liabilities. So that's all I have. Thank you, Mr. Chair, and thank you, Janet and TJ.
Thank you, Representative Thompson. Representative Armstrong.
Thank you, Mr. Chair, and thank you, Janet and TJ. This is helpful. As an example, it's been a long time, and hopefully they've streamlined their process since then. But at one point in my career, I was licensed in Michigan at the time and tried to get a license in Wisconsin. And at 6 months, I gave up and I went elsewhere. It was so long and burdensome. And I had all the information, but everything from my marriage certificate, birth certificate, driver's license, transcripts, test results, background checks, a lot. And it took a long time, and I finally gave up and never got a license there. So it can be enormously burdensome. For no particular good reason, as we were talking this morning, looking at requirements that impact the health and safety of individuals, why on earth they would need my marriage certificate, I don't know, don't understand. But anyways, that's some kind of, in my mind, egregious kind of examples. But I have a couple of clarifying questions, and that was helpful, TJ, to walk through what happens to get it, because that was one of the things I wanted to highlight, is that your role as a commission is largely administrative in tracking all the different licensure requirements and the privilege applications and then any disciplinary actions across and among those. So the board here actually is not burdened by processing those applications for privileges. Is that correct?
That is correct. The the commission is the one that administers all the vetting and the issuance of the compact privileges. So it would actually remove that burden from the board.
And it was useful to hear you say even doing the jurisprudence exam, you direct them there, and then they have to complete that. And I'm assuming, are those usually online, the jurisprudence exams?
It depends on the state, and New Mexico, Janet might be able to speak to this more than I can, but it depends on the state. Some have them online, some are in person, but it's because every state's different. We do direct them back to the state to administer however they choose to administer their jurisprudence exam.
Okay, and then the state, so the state does have that particular role for their jurisprudence piece, and then the state notifies you that the person has taken that jurisprudence and passed?
No, in this case, the individual, we have several attestations during our process that they attest that they truthfully have completed and passed the exam for the state that they're selecting. And then on the back end, the only administrative side that's left for the state is to verify that the person who's got a compact privilege has truthfully attested that they did and did in fact complete the jurisprudence exam based on a list that they have of those who've completed it for them. And so that is really and the state could take action against an individual if they made a false statement that they did complete it and had not done so.
Thank you. And I assume that if somebody had done that, lied about having taken that or not successfully passed it when they said they did, they'd be subject, I would assume, not only to losing that privilege in the state, but then, as you said, if you lost it in one state, it gets pulled in all the states.
Right. It would be up to the states what action they choose to take. So again, like anything else, if somebody had made a false statement on an application for a license, for example, they could additionally take action just like that on a compact privilege. If they made a false statement, they could determine to open an investigation and then determine what actions they want to take against that person. Some states choose to take remediation action, which means that they're just trying to get that person to actually take the exam before they practice in the state. Some states go further to require voluntary surrender, and even further, some states will take disciplinary action, and that would be reported to the NPDB. And in any case, obviously, they would be, if they took a disciplinary action, they would become immediately disqualified for a period of at least 2 years to get compact privileges anywhere else.
Okay. So while New Mexico, just as an example, might be really lenient on that, another state might not, but it would preclude them from practicing here as well. So there's consistency in that way. And then let's see, I did want to ask a clarifying question about the background check. Because FBI national background checks require legislative authority to do that, I just want to clarify, in New Mexico, Janet, you said it was done by regulation, and I'm wondering if that's just state background check, if it meets the federal requirements, and if we, in doing the compact, also need to do an amendment to the state statute that gives, that specifies that federal background check, because it's my understanding the FBI won't do it if there's not legislation in the state requiring it.
So, Mr. Chair, Madam Vice Chair, members of the committee, this is Janet Popp again. So, yes, there is a rule, and we've tried to get some clarification about this background check requirement and if it does comply with the federal requirements. In the meantime, and we haven't, from the licensing board, we haven't been able to, receive that confirmation yet. But in the meantime, the APTA has issued a very comprehensive document on the guidance that requirements for the criminal background check, and it does have to be in statute. It cannot be a rule. So I can share that information with you. That was just released, gosh, I think maybe 4 days ago. So it's hot off the press. Yeah.
Okay, and I'm wondering whether by signing, if we do legislation for the compact, and the compact requires it, if that by extension is enough statutory authority for the state. It'd be a legal question.
This is TJ Cantwell. So I can speak to that to say that we have confirmed with the FBI that our language, just that the existing compact language, is not sufficient enough. If you do not have existing language, we do have actual guidance if the state is determined to need to have the FBI criminal background check language added. We do have additional suggestive language that can be, again, added as an addendum to the compact, not within the compact language itself, because that cannot be changed. Mm-hmm. But we do have other suggested what other states have done in order to be effective in changing some other statutory language to make sure the FBI criminal background check will be approved by the FBI. But as it stands, our existing language, as the model was set up years ago, was determined not to be enough for the FBI. So we had to get additional language kind of drafted in order for that to be effective for those states that don't already have it. But as was said, we're not exactly clear yet whether or not the state board, New Mexico State Board, has such authority already. We don't. I don't think they do, but again, I'm not aware of it, whether or not they do or not. So we'd have to clarify with them first.
Thank you. I appreciate that. And having been engaged in FBI check language on different entities off and on for 20 years, my guess is just doing a rule doesn't cut it. That we will need to, when we do New Mexico's compact, we'll need to have that addendum to give specific authority for the background check. I'm guessing there's no way a rule would be sufficient if your compact language isn't sufficient either. So I'm just highlighting that for folks as we work on this to add that. And then I just wanted to make another clarifying question. So it's to get the license, your original license in a state that you are holding the license, you have to follow everything that's required to get that license, including the continuing education. But your practice, the delivery of services, when you are in a compact state, another state, so you have a privilege in another state, you have to follow all the rules around practice and scope of practice in the state that you're delivering the service in. Continuing education is tied to showing competence to get your license, not tied to the practice. So you're following the continuing education requirements in the licensing state, even though they may be different in the state that you're privileged in. Do I have that correct?
Correct.
Okay. But I think you also said, TJ, that part of the compact is a requirement, that there is a requirement for continuing education tied to the license. Is there a minimum? Because you showed, I think Janet showed us several states around us, and it varied from 20 to 40 hours in a 2-year period. Is there a minimum number of hours that you require to participate in the compact, or just that there is some requirement for continuing education?
There is no minimum. It's just that there's a requirement for continuing education for both PTs and PTAs, which, again, most states were already doing. But for those states that may not have required it for PTAs, for instance, I believe Colorado was that case, they had to actually institute that in order to be part of the compact. But okay. we do not get involved in how many that is per state.
Okay. But we do know that everyone has some minimum amount of continuing education to keep renewing their license if they're part of the compact. Okay. And I would assume that some states are different in how often they renew their license also. We used to be every year, it moved to every 2 years. And I would assume there may be even some states that are longer than that.
Correct. There are, it varies widely across the board. Some states are 1 year, some states are 2 years. In fact, most states are 2 years, but then other states do it on an odd even year, break it up by last name, the start, the first initial of your last name, birth dates, anniversary. So it really varies by state. And so that's why we tie everything to the home state license. And so that does also streamline the process for folks getting compact privileges. They no longer have to worry about what the renewal is for every state that they have a license is. They just have to worry about that home state renewal date and make sure they can go back and renew everything at the appropriate time.
Mm-hmm. Okay. Thank you. I think just a comment, and I know it's not in the compact, but since Senator Cedillo Lopez brought it up about liability and malpractice, I don't think PTs have a high malpractice rate. But putting that aside, I would think, as her example, if someone works for a company in Maine but is privileged in New Mexico and delivering a service in New Mexico, as an employee of that company in Maine, I would assume that company in Maine's got a contract with somebody to deliver service. But I also think that if it's their employee and that employee is privileged and practicing here, that's enough of a connection if you to provide some the jurisdiction. So I see the senator nodding. I'm trying to think it through also as to what that would be. But I think you have to follow the practice laws in the state that you are delivering the service, and that gives a clear connection to that individual should there be a malpractice related to delivery of a service in our state, I think. So, but I'm happy to keep talking about that, Senator. If you, as you keep thinking it through, if there's more issues around that, but since they clearly have to follow the Practice Act here in how they practice, including jurisprudence, have to understand that act, then I think that certainly gives a connection for jurisdiction. Mr. Chair, I think that's all I have. I want to thank Janet and TJ for your presentations, and as a former PT licensed in multiple states and jumping through those hoops just when I moved and relocated to different states, I would have loved to have been able to do this. It would have solved a lot of personal problems to get going in being licensed and working in a new state. So, thank you.
And Dave, factor coming at 3. We need to make sure the dogs are in, but you're going to need to talk to them when they come. Knock the door. It's going to be so.
Somebody has their mic on. If they could. I wanted to ask Representative Garcia if you're on. If you have any questions.
Chair, thank you. No questions at this time, Mr. Chair. I'm busy cutting my toenails.
Oh, too much information.
That was definitely too much information.
But I do notice that Representative Tara Lujan has a question.
Yes, Mr. Chair. Yes, to our presenters. I just have a question about, are there any extra or associated costs when providers are moving across states, providing services under the compact?
So under the compact, what they need, as was mentioned earlier, they have to pay the fees. So there's a $45 commission fee, which again, how the commissions maintains and operates itself. And then there is a whatever the state fee determines what they want to be assessed. Otherwise, there's no different fees for somebody that would be coming to practice in the state versus a compact privilege holder. I would say that, one thing to consider is that the licensees, and I'm sure those who are PTs on this committee can attest to, there are other fees that have to be paid in order to become a licensee. In addition to a license fee by the state, you usually have to pay a score transfer reports fee, and potentially, any other fees that are associated with that from the state board. But the, fees for the compact are very upfront, and again, just need to be paid at initial and renewal of any compact privileges for that state. I think, does that answer your question?
Mr. Chair, TJ, thank you for that response, but I guess, and excuse me for not being specific about it, that's part of what I'm asking. But what I mean is there a billing cost to the service for patients to use? I mean, is there kind of a trickle down expense that goes on to patients that need to have service from an out of state provider, so to speak?
I'll take a stab, if you don't mind my jumping in. I would think that if you are doing a billing per service, like to the, say you're that individual therapist from out of state is practicing at a rehab center. The bill and how much you would be able to bill for, get paid for, is exactly the same. However, you may have either the rehab center or a school or a nursing home or something that hires a therapist that is employed by a travel agency, places that therapist there. So nurses do this a lot. Where they're called travelers and they work for a placement agency that places them. That often costs that institution who's hiring through a placement agency like that, costs them more per hour or per salary equivalent than it would if they hired someone themselves, but they've just not been able to find someone. So it may cost the institution more if they're working through a placement agency as opposed to the individual. What you can bill for the service, though, would be the same.
Mr. Chair, Representative Armstrong, thank you for that. And that's kind of what I'm getting at, because I do understand how that works with traveling nurses and that, coming down as added expenses. And I'm just wondering if that's, I know we're just speaking to PT or talking about PT today, but it is a concern, and I'm just wondering if that is in effect here as well. And and the other issue I have, or I'd like to talk about, is the continuity of care, and how if there's an interference or if you looked at that, and if that is an issue as well with services to patients.
This is TJ again. I would first just add on to what Representative Armstrong said, which is to say that she's correct in far as the billing, and I think for travel therapy, but that would be no different between somebody getting a license or getting a compact privilege. It would still be the same, whether they came here from a travel company, which many do right now, into the state to travel and to work temporarily in the States under a license. Again, that would still apply for if they have a compact privilege as well, or a license. And then as to the point of continuity of care, what we found is that the compact itself has actually done a lot to improve continuity of care. The ability for somebody to more easily get a privilege to practice in another state. So in many cases, if you're speaking to the fact that individual PT or PTA may be only temporarily in the state to fill a role and then leave. That's one side of the coin. The other side of the coin is when a individual that's actually a patient in the state of New Mexico leaves and moves to another state, or even temporarily takes, a vacation or another assignment in another state, then they lose that continuity of care because that individual PT or PTA that they've built a relationship with now isn't licensed in another state. But under the compact, they can much more easily and quickly become licensed in that state and say, again, as we were talking about Colorado, say some patient is going to go on a month-long vacation in Colorado, and they say, well, I'd like to still be able to get remote services there, or I'd like to be able to still talk to you there. There's no way for that individual to be able to get that kind of service out of state right now. If that person's not licensed, they'd have to go license and go through that process through Colorado. But under the compact, they'd be able to do that within a matter of minutes in order to get a privilege to practice in the state of Colorado and be able to maintain that continuity of care there. And as I said before, I think in many cases, the practice of someone coming to be able to locum tenens or do something that's going to be a temporary work within a state is currently ongoing under the current licensure structure, just because of the unfortunate lack of qualified PTs and PTAs in certain areas, especially rural areas of a state, and this does a lot to try to fill those gaps and make it more possible for more qualified and people that want to practice and want to be able to practice and go to those areas to be more quickly identified and be able to work in those states.
If I can add to that, as an example, without a compact, if you have someone in New Mexico, licensed in New Mexico, who is near a border and wants to be able to practice in both states, say Las Cruces and El Paso, they would have to get licensed in both states, maintain the continuing education in both states, pay the licensing fees in both states, and which is much more burdensome than this privilege, which may, I hope, will open up our ability to attract therapists and be able to utilize therapists without going through a staffing agency, because it will be much easier to be able to practice across state lines, and that applies to all our border states who are all in the compact now, that we may be able to recruit and utilize much easier than it would be. I can tell you, particularly with my experience having tried to get licensed in Wisconsin, and I was actually living in Michigan. So I would have done it and practiced in both states, but it was too burdensome to get the license and keep up with it in two states. So this may help for recruitment without utilizing as many placement services.
Mr. Chair and Representative Armstrong, thank you so much for that. And yeah, those are the things that we're quite aware of. We need more providers, we need more therapists in all practices in medicine in our state. And so those are just clarifying questions I have, and you've really brought to light those aspects. So thank you so much. And I'm sure there'll be more questions, but I really appreciate those responses. Thank you so much.
Thank you, Representative. We still have two others with questions, Representative Gail Armstrong and then Senator Liz Stefanik.
Thank you, Mr. Chair. Sorry, I must have my hand up inadvertently. My apologies.
Okay, Mr. Chair?
Yes, we can hear you fine.
Okay, thank you. So I think many of my questions were answered, but I want to just clarify. So out-of-state PTs would still have to register with our board, our board would have the opportunity to track how many out-of-state PTs there were or PTAs. But wouldn't we also lose some licensing fees? And just reassure me about that, those few questions. Thank you.
So the answer to your first question with terms of tracking, yes. So the member states, the compact member states, are all notified of any individuals that get compact privileges within their state. In addition, they have access to a back-end reporting site where they can run at any time and see who all people that have compact privileges in their states. And in terms of the ability for, or the possibility of the state losing revenue due to licensing fees, what we found, and again, we've been early on, so I can't point to specific statistics or numbers yet, but we are working on putting that kind of information together, is that in many cases, states may see a change in the way people get compact or get the privilege of practice in the state. So they may change from potentially getting a license in New Mexico or getting an endorsement in New Mexico. But the advantage of the compact is that since the state can set whatever fee they choose on a compact privilege, there is really very little loss of revenue in terms of the ability for them to say, we feel for every compact privilege, it should be X amount of dollars. That state, we collect that on behalf of the state, we remit it back to the state. And so they can still have a revenue stream coming in for compact privileges that would replace those that might be lost through endorsement or through somebody getting a regular license in the state. So that is, we found to be very minimal. The other aspect of it is that when there's multiple licensees, that somebody may just switch from one to the other. But in the case of New Mexico residents, what we found, there's likely a lot of people that are living in New Mexico that may have licenses in other states, especially ones that are along the borders, and potentially working across the state border in another state. They may not have a license in New Mexico yet. And so what we found is in several cases, individual PTs or PTAs may go ahead and actually get a license in New Mexico for the first time, because then they can have that license and then get compact privileges in other states, since they're easier to get and easier to maintain. Again, we're early on, so there's not a lot of numbers to back that up, but through anecdotal cases and through some investigation with different states, that's what we've seen, that really, because of the way we're set up, and we are different than, say, the nursing compact, which has a set fee for getting a compact privilege. Ours is really varied by state. So some states charge $0, some states charge $250, and they're able to, again, then recoup the costs that they would otherwise have lost from licensure fees.
Thank you for that response. I do think that we here, Mr. Chair, might want to think about any loss of fees, because our boards and commissions are so dependent upon these fees to operate. But thank you very much for your time. Thank you for the presentation. I'm finished.
Mr. Chair, you need to unmute.
I want to thank you both for your presentation. I think we've had a chance to ask all the questions we had, and we've certainly clarified our understanding of what the compact entails. So thank you, both of you, for coming. And we'll move on now to our next presentation, which is nursing scope of practice issues. We've got Shannon Allen, from the president of the New Mexico Association of Nurse Anesthetists, Gloria Doherty, an adult health nurse specialist, and Angela Fritz with the New Mexico Association of Nurse Anesthetists.
Can you hear me okay?
Yes.
Okay, Mr. Chairman and committee members, I want to thank you, first of all, so much just for inviting us here today. And also thank you so much for meeting with us over the last 2 years. It feels great right now to see all your friendly faces and know the time that we've spent with so many of you. And so just thank you for all of your support the last couple of years. If I haven't had the opportunity to meet you, my name is Dr. Shannon Allen, and I'm a nurse anesthesiologist. I am also the current president of the New Mexico Association of Nurse Anesthetists. I have been a nurse in New Mexico for 31 years, and 20 of those years I've been doing anesthesia. It's been a very rewarding career. We have the trust of our patients, we have the trust of our surgeons, our colleagues, coworkers. So it's really an exciting profession to be in. I have Angela Fritz here with me today, and she is the incoming president starting in October. So I'll be handing her the baton, and I wanted everyone to have the opportunity to meet her. And I will be staying on as past president and also the government relations chair. So you'll be hearing quite a bit from us together this year. But we wanted to talk to you a little bit about who are CRNAs, the timeline that we have been taking care of people here in New Mexico, a bit of a barrier that we have encountered, and a solution to that. And so I'll just start with letting you know a little bit about who we are as a profession. So there are 500 CRNAs that practice in New Mexico. The majority of those are residents here. We have some that we call locums, which means they travel from other states and they come on vacations and that. But we first are critical care nurses before we go to school to learn to do anesthesia. Well, I personally was an ICU nurse and an ER nurse for 10 years before I ever went to school to learn anesthesia. And so that gives us this unique ability to be able to care for these critical patients. We have 7 to 9 years of schooling when we graduate. We either have a master's or a doctorate when we get out of school. And in the next 2 to 4 years, and I can't remember the exact year, I want to say 2, all of our graduates will be graduating with a doctorate degree. So we're a pretty progressive profession. We were the first profession to actually do anesthesia. We've been doing it for over 150 years, so I'm quite proud of my colleagues. And we have remained at the forefront of anesthesia care. I wanted to let you see what a great impact we have had on New Mexico. We are actually there filling in the gap in healthcare needs in the small areas. And just to show this point, we have many all CRNA groups across the state. And some of these areas are Hobbs, Roswell, Deming, Clovis, Portales, Taos, Espanola, Gallup, Grant, Alamogordo. So there are many towns in our state that are relying solely on CRNAs to fill this healthcare need for our patient. So we really have been able to make a huge difference in the state for our patients' healthcare. I just wanted to tell you a little bit about the timeline of our practice. We have been practicing in an independent manner for about 18 years. 18 years ago, Governor Gary Johnson in 2002 signed what is called an opt-out agreement, making us an opt-out state. And what this does is it removes the physician supervision requirement and allows CRNAs the flexibility to be able to provide healthcare needs in our state. And I attached this opt-out agreement. It's the 4th page of the packet that I gave you if you'd like to read it. But CRNAs have been here. We've been doing general, regional, obstetrical healthcare throughout the state. We provide pain management. We have CRNAs who specifically go above and beyond and train to do things such as lumbar back injections. You know, we have patients with chronic back pain. So we're really helping to fight this opioid crisis because our CRNAs are helping these patients overcome this. And without us, in some of these rural areas, they might have to travel for several hours to a larger city to go and get this care. So here in the last year, you know, I've met and spoken with many of you, and I do appreciate the time that you shared with us. We've also spent time with the governor's office, introducing ourselves, letting them know who we are, and also with the Board of Nursing. And we have support, and they both feel that we should be practicing to the full scope of our training and education and national certification. And we have been allowed to do this for the last 18 years. And we do have a bit of conundrum, though, with the wording in our Nurse Practice Act. It's not really congruent with the way that we've been practicing. And I wanted to introduce you to Angela, and I wanted to give her the opportunity to meet you and speak with you. And she's going to talk to you a little bit about that nurse practice language.
Okay, thank you so much, Shannon. Thank you, Mr. Chairman, for having us here today, and committee members for being here. My name is Angela Fritz. I'm also a certified registered nurse anesthesiologist. And as Shannon said, I'm the incoming president for our association. And I too have had the pleasure of serving in healthcare for the past 30 years, and 10 of those years in anesthesia. So I'm really delighted to talk to you guys today about some of our concerns, and then hopefully be part of the solution of this along with you guys. So Shannon kind of talked about what we do and what we're hoping to gain, but I wanted to just discuss with you for a second what the barriers are, and why do we want to pursue this. The Nurse Practice Act has a little bit of confusing language for APRNs, the Advanced Practice Registered Nurses. The nurses, the APRNs of New Mexico, the clinical nurse midwives, the nurse practitioners, they have very clear and concise language in the Nurse Practice Act. It says that they practice independently, and the wording concerning the anesthesia nurses is that it's interdependent relationship and collaborations with licensed physicians. That could be a podiatrist, that could be a dentist. So it's a little confusing, the language in the act, and it's exceptionally incongruent with what we're trained and licensed to do. So another potential barrier for us is that, as Shannon's already mentioned, Governor Gary Johnson signed this opt-out 18 years ago. So what happens if we get a new governor that decides to eliminate that opt-out, and then now all of a sudden we're required to have this supervision for our practice? So we see this as a huge problem, resulting in limited access of care for citizens all across New Mexico. I came from Deming. I used to work in a real critical access hospital where I was, the only provider. So if that was to go away by a new governor's signature, then, that would eliminate the need or the ability for us to do surgery in some of these smaller hospitals. So, and then lastly, as far as barriers, we just really think that this language in the Nurse Practice Act is very confusing to hospitals. It's confusing to people that sit on hospital bylaw committees and decide, well, do we go by the legislation of the governor for opt-out and allow our CRNAs to practice independently here, or are we supposed to follow the Nurse Practice Act? So really what our request is of you, or what we think the solution is we would like to ask you to help support us in updating the language of this Nurse Practice Act and making it consistent for all the advanced practice nurses, and that would include the CRNAs. We would like the language to reflect independent practice for us, like we've already been doing for the past nearly 2 decades in this state, all across the state. And if you have the attachments, the package that we sent you, if you'll refer to page 6, you'll see a yellow highlighted area. This is a actual page from the Nurse Practice Act. And in this highlighted area, it talks about nurse practitioners, and the language states that they do practice independently. And that's on page 6 of that attachment. And if you scroll down one more page, on page 7, you'll see the language for CRNAs and the words interdependently and collaboration with licensed physicians. So it's just, like I said, one more time, it's just incongruent with what we're already practicing, the independent manner in which we are already performing anesthesia all across the state and have been for well over 18 years. So in closing, I just want to ask for your support. So as we work with legislators to draft a bill to present in our upcoming session to update this language. Again, I want to reiterate, we are not asking you to change our scope of practice, to change anything about our practice in any way, as this is not a scope of practice issue. And so ultimately, no matter how it's voted on, we still go back to work Monday morning and practice exactly the same way, taking care of our patients as we always have. So this ask ultimately is to help secure the access of the residents of our state to buy them an insurance policy, so to speak, so that they'll always have that access. And it allows, for the APRNs of New Mexico to all have congruent language in the Nurse Practice Act. So that's pretty much it. I won't take up more of your time. I know it's the end of the day and you guys are all tired. So I just want to thank you, Mr. Chairman and committee members. And at this time, if there's any questions, we're happy to answer those.
Thank you. Thank you, Angela. Thank you, Shannon. We're going to hear from the rest of our panel before we go to questions, but I just have a clarifying from Andy. Did we get a packet of information from the nurse anesthetist? And I'm not hearing from Andrea. If you're muted or if you're there, if you could let us know. I'm not sure that we have. I might have missed it, but it's not posted online among handouts. So we will make sure to follow up with you and get it to all of the committee members and post what's appropriate online for handouts. Oh, there's Andy.
Yeah, hi. I'm sorry, I had to take a bio break. What was the question?
The question is whether we have a packet of information from the nurse anesthetist for the committee.
I believe that we do, and I think that Chris Balzano sent it to us either last night or this morning, and and it should be posted.
It's not, so if we could get that posted and if you could make sure it gets sent around to all the committee. If I received it, I totally missed it, so
okay.
So we'd like to have that for our files.
Right, okay.
Okay, thank you. Thank you, and Shannon and Angela, if you would stick around. Next, we will go to Gloria Doherty. And you'll need to unmute. Gloria, you're muted. There you go. Oh, we still don't hear you.
Nancy, is Gloria on?
She's on and it shows her unmuted, but.
Suggestions would be to turn up the volume on her computer. Does she have anything else plugged into it? Other than that, I can let IT know and we'll see if we can get some help.
Or Gloria, you might be able to call in. We can't hear you.
Also, where you mute and unmute, there's a little drop down and it has a microphone. It says use system setting, or and there's another microphone in there.
Can you hear me now?
There you go. Very
you can
good.
Hear me now?
Yes.
Yay!
Yay. Once we're over the pandemic, we'll all finally have this down pat.
All morning. Okay, great. Sorry for that delay. Thank you, Madam Vice Chair Armstrong and Chairman Ortiz-Pino, although I don't see him. My name is Gloria Doherty, and I have been a nurse for 30 years and a nurse practitioner for 20. I am the current president for the New Mexico Nursing Association, the legislative committee chair for the Nurse Practitioner Council, as well as a member at large for the New Mexico Nurse Practitioner Council. And I truly appreciate your patience while working those things out. And on behalf of the Advanced Practice Nursing Council and the New Mexico Nurse Practitioner Council and the New Mexico Nursing Association, we're coming to you with the following considerations for the upcoming 2021 legislative session. Just to give a short legislative history of how we got to the wonderful place that we are now. In 1993, the nurse practitioners of this state, with bipartisan and bicameral support of this legislative body, we were able to achieve independent practice, which included full prescriptive authority. 27 years ago, that did not exist. There were few, if any, states that had independent practice and prescriptive authority. Prior to 1993 in New Mexico, we had a collaborative agreement which a nurse practitioner had to have a physician in order to deliver care to their patients. And the prescriptive authority that we had barred any controlled substances. So we've come a long way, and fast forward 27 years, and there are nurse practitioners who have their own practices. During this time, the nursing community stood united with the colleges of nursing, the medical society, and other community partners to achieve one goal. And that goal was to improve the access to high quality care for the citizens of New Mexico. Members from each of these groups and other allies provided expert testimony to the forward-thinking legislature. Today, we have 28 states with independent practice, and there are 2,000 nurse practitioners licensed in the state of New Mexico, over 2,000. We practice in every possible specialty, and we touch all walks of life through every phase of life. Many of our rural areas are covered predominantly by nurse practitioners, similar to what was given in the CRNA testimony about working in Deming with Angela. Many nurse practitioners have their own practices. Others work within groups where they have a variety of healthcare settings. And our citizens of our state have access to high quality care, and it's been improved for the citizens of New Mexico. The vast majority of nurse practitioners still practice in primary care and certainly provide safe, high quality care to the citizens of our state. There are numerous studies that exist showing the safety and efficacy of nurse practitioners being equal to other healthcare providers. The satisfaction of patients who are receiving care from advanced practice nurses continue to be very high. During the time of negotiation for us receiving independent practice and full prescriptive authority, there were some compromises that were made for that legislation to pass. This includes two things, which I would like to speak with you about today. The first is the need for a formulary being submitted to the Board of Nursing by the advanced practice nurse. and the second to dispense medication. We would like to ask for your support in eliminating the need for a formulary to be submitted to the Board of Nursing. It is an antiquated practice which is not followed, monitored, or enforced. Today's healthcare and medication choices are guided by the formularies that are created by the institutions and facilities we work for, the healthcare programs that we are signed on for, and insurance companies. In addition to that, science and technology and research has improved greatly. There's new medication classes being added all the time, not just medication. And you could see that during any television show that you're watching where a pharmacy commercial comes on claiming that it's the best and greatest for X ailment or chronic illness. It is impossible to keep up with all of the medications being added and all of the classes, along with the paperwork trail that's affiliated with it. This can be found in the nurse practice statute, where certified nurse practitioners who have fulfilled requirements for prescriptive authority may prescribe in accordance with rules, regulations, guidelines, and formularies for individual certified nurse practitioners promulgated by the board. We ask that that latter part of the sentence be struck. And we, of course, will follow the normal route with getting sponsors, et cetera. It is also within the Nurse Practice Act when it is involving other advanced practice nurses, including the certified registered nurse anesthetist and the clinical nurse specialist. We do not anticipate any issues with bringing the statute to reflect current practice. This includes communications with the executive director of the Board of Nursing through the New Mexico Nurse Practitioner Council and conversations with the New Mexico Medical Society. The next piece regards the addition of dispensing to the statute. Currently, the Nurse Practice Act allows a nurse practitioner to distribute to their patients Schedule 2 through 4 scheduled medications that have been prepared, packaged, or fabricated by a registered pharmacist or dose prepackaged by pharmaceutical means in accordance with the Pharmacy Act and the New Mexico Drug and Device and Cosmetic Act. We propose that dispensing be added to this paragraph. Representative Gal Armstrong sponsored this bill in the last session, but it was not germane. There are nurse practitioners in rural areas that are providing care to patients, your constituents, that would benefit from this ability. A nurse practitioner from Magdalena reached out to Representative Armstrong and brought this to our attention. In addition, psychiatric nurse practitioners who are all over rural areas, as well as nurse specialists, can improve care to their clientele with this ability and help in the fight against opioid addiction and polysubstance abuse. Both the Medical Society and the Board of Nursing have been communicated with, and all agree that this provides better access for the citizens of New Mexico and their continuum of care. Precedent exists with the Board of Medicine statute for physician assistants that was just updated during the last 2019 legislative session. It includes the definitions for dispense and distribution, and it can be found in that act, where dispense means, quote, to deliver a drug directly to a patient and includes the mixing, labeling, and repackaging of a drug from a bulk or original container. And distribute, quote, to administer or supply a patient under direct care of the distributing physician assistant prepared or repackaged drugs or the manufacturer's original container or containers for a quantity suitable for the prescribed treatment or condition. There are also other states in our country who have this in their Nurse Practice Acts, including New Hampshire and Minnesota. For New Hampshire, an APRN quote, shall have plenary authority to possess, compound, prescribe, administer, and dispense and distribute controlled and non-controlled medications within the scope of the APRN practice. For Minnesota, quote, advanced practice nurses can prescribe, procure, sign for, record, administer, and dispense over-the-counter, legend, and controlled substances, including sample drugs. Next, we would like to provide an update to the legislation which you all assisted in successfully passing in the legislative year 2019. Specifically, the nurse practitioner and nurse midwife parity, which started out as House Bill 280. This required all healthcare facilities, unless required by federal law, to apply the same privileges to nurse practitioners, nurse midwives, and nurse specialists as applied to physicians with regards to granting patient admissions and discharging and for continuing care. Patches agrees. And it also requires nurse practitioners as acting in accordance with the professional scope of practice and are eligible to serve on the facility's medical staff, credentialed under the same procedures that the physicians are allowed. It also asks that nurse practitioners are able to do peer review on their professional colleagues. There are still many difficulties with facilities failing to comply with this law that took effect on July 1st, 2020. We may need additional legislation to clarify the intent of the existing law to these facilities who have not participated. Other institutions have complied without any issue. For example, I work at Sandoval Regional Medical Center now, and there I am considered part of the medical staff. I admit my own patients, I follow them through their stay, and I'm able to discharge them as well. There are other institutions who have not implemented this law yet. The archaic culture remaining in existence in many facilities must be transformed so that the improved access to quality of care that we have afforded the citizens of New Mexico with independent practice can be enhanced through allowing nurse practitioners to admit, follow, and discharge their own patients throughout the continuum of healthcare. Another example that I can provide, other than nurse midwives, which have the obvious, they take care of them prepartum, peripartum, and postpartum, perinatal, prenatal, sorry, obviously not a nurse midwife. But I can also give an example of my cystic fibrosis patients. I cared for this very specific population for over 2 years. It is a highly ever-changing realm of a very chronically ill, sick group of people whose lifespan used to be only 23. My oldest patient is 73. But that's with changes of guidelines, changes of medications, and great breakthroughs that have improved both length of life and quality of life. When these patients get sick, which happens at least annually, they have to be admitted to the hospital. Prior to this, I had to have a hospitalist service admit my patient, and I was considered a consult. And often length of stay was increased. Plans of cares were made that their socioeconomic status nor their willpower wanted them to be able to adhere to. So that changed, and I was able to admit my own patients, and I followed them 7 days a week, 24/7 of call, and I was able to make sure that those patients got what they needed as individuals, regardless of what the plan of care the hospitalist had that was theoretical. It was specific to that patient. And knowing those patients inside and out make all the difference in the world, and it could be a safety issue for somebody else to take care of them. The last item I would like to share with you all surrounds another multi-state compact. I got to listen to the conversations that were going on and the concerns about the compact with the physical therapist, as well as I was a huge part of the nursing compact that went through. If you recall, there was bipartisan, bicameral action to expedite the passing of the nursing licensure compact, multi-state compact, to avert a healthcare crisis in our state. We had so many travelers working on the compact in the border parts of our state that if we did not join that pact quickly, we would have lost all of those healthcare workers and taking care of those patients in those areas and those hospitals. The bill was passed in 24 hours, and many legislators had the same concerns that the nursing community had with the compact. Attempts to right those concerns in the legislation that we introduced in 2019 could not move forward because the National Council of the State Boards of Nursing threatened a lawsuit against the state. During that time, some of the nursing community had concerns regarding the compact, and prior to its passage, the previous executive director of the Board of Nursing tried to enact on his agenda to pass an advanced practice registered nurse compact as well. The APRN nursing community stands against the enactment of an APRN compact. Last month, the National Council of the State Boards of Nursing met and changed some items related to the enactment of the compact, including naming the number of hours a nurse practitioner must practice before being eligible for independent practice. This type of language does not belong in our statute where we have already gained independence. It would delay entry into practice. It would delay entry into areas where access is needed. It would have implications for colleges of nursing and practice restrictions for nurse practitioners in our state. It would be a step backwards. Our state could end up losing the momentum that we have gained over decades. Additionally, and without any rationale, the National Council decreased the number of states needed for the compact to be enacted from 10 to 7. Discussion did not complete before our roll was called. And similar to the physical therapy compact, there is one delegate per state, only it is named for this commission that it is the executive director of the Board of Nursing. Included in this also is the concept of nurse practitioners being able to come to this state without even notifying the Board of Nursing, different from the physical therapists where they actually have to register with their board. With this compact, they do not have to register with our Board of Nursing. So they can come to our state and set up their own practice without the Board of Nursing even knowing they're here. Obviously, that sets up public safety issues. How would DEA and prescription monitoring program participation be enforced if the Board of Nursing is not cognizant that the practitioner is here? This is a huge safety issue for the public. We propose, in the setting of public health emergency or the declaration of a state of emergency, such as what we are currently living through, that the Nurse Practice Act has verbiage added to it to allow nurse practitioners to come from other states that are also independent in practice with full prescriptive authority to come here and register through their board and be licensed and be able to come practice here. It would require emergency licensure to be administered by the Board of Nursing or through the Department of Health and the Department of Homeland Security and Emergency Management. It would allow the knowledge of the provider's presence within our state and maintain public safety for our citizens. There's also a huge issue on how much revenue the New Mexico Board of Nursing would lose and instill upon subsequently to other nurse practitioners through licensing fees to make up the difference. There's also unknown fiscal implications related to disciplinary hearings, which would not be in this state, and the Commission's assessment fees that are related to operations that would be done retrospectively, so it couldn't even be budgeted for. There's also concerns regarding the use of proprietary data that includes identifying information that the Commission would require, and since that hasn't been outlined, it could be items that are unlawful to submit through the Board of Nursing. And then that data becomes their own. What are they going to do with that data? Will the Board of Nursing be able to elicit that data when somebody is coming here and being considered for licensure in our state? Another fear of the compact's implications resulting in the step backwards for APRN practice surrounds the idea of, quote, the Commission by rule shall identify the APRN roles and population foci for licensure, end quote. Why should the Commission determine or have the authority with regard to our population foci? This is specific to our education, our training, and our certifying body. Our state would have a lot to lose if they did what the rest of the states have and don't have certified nurse specialists working independently. We would have a lot to lose because University of New Mexico had a program as for psychiatric nurse specialists up until about a decade ago. The predominance of our behavioral health workers throughout the state are nurse specialists, particularly in the rural areas, and they prescribe, they help with the behavioral health crisis that we are always in and with opioid replacement treatment and substance abuse management. There is an endorsement that I sent with the paperwork that got sent to you all. I don't know if you received it, but is the provision currently that we have for New Mexico and with the Board of Medicine, where the Department of Health and the Department of Homeland Security and Emergency Management shall credential out-of-state professionals who can render aid and necessary services during the pendency of this order. During an emergency, a person who holds a license, certificate, or other permit that is issued by a state or territory of the United States and evidences the meeting of all qualifications for professional or other skills may be credentialed, if appropriate and approved by the Department of Health or Homeland Security and Emergency Management Department, to render aid involving those skills to meet an emergency, subject to limitations and conditions as the governor may prescribe by the executive order. And this expires in August 28th. It expired August 28th, 2020. In conclusion, the APRN committee does not want to see this legislative move forward if it is reintroduced. It is premature and it is wrought with uncertainty and can bring numerous public safety issues to our state. We already have so many vulnerable populations. Consider if the Board of Medicine decided to try to pass legislation where they can join a compact that allowed any doctor to practice in New Mexico, and they can come and set up shop, and the Board of Medicine would never even know. Think of all the awful things that could happen. The same could happen if the Board of Nursing was put into place to put through this APRN compact. Both the New Mexico Nursing Association and the New Mexico Nurse Practitioner Council see reciprocity as a realistic way to expedite licensure to those in good standing that meet all the requirements, minimal requirements of licensure in New Mexico in our state. And it would further provide knowledge to the licensing board of who is in our state and rendering care to our citizens. The very last thing that I want to bring up is we are continuing to find areas in rules and regulations and statutes where it states, quote, physician, end quote, regardless of what it is for. And I'll give you an example. A nurse practitioner was taking care of a police officer. This police officer had to shoot a perpetrator. During the shooting, there was a blood transference. The nurse practitioner had to call the Office of the Medical Investigator to find out the HIV status of the deceased perpetrator. The investigator told the nurse practitioner that only physicians were allowed to receive that information. As you can imagine, this impedes care for that patient and for that nurse practitioner, and this happens in other places as well. There would be a delay in treatment for very important prophylaxis for that police officer who was in an unfortunate situation. This is just one example of how this can impede care. And we will continue to bring things to light of this legislative body as we continue to find them. I stand before you now for any questions or commentary.
Thank you, Gloria. And like with the previous speaker, I don't believe that we have your materials, at least as committee members. So if you send it in, we'll make sure it gets to committee members and posted for handouts for the public. So thank you. But I don't think we have it at the moment. Committee members, remember, if you wish to ask a question, to raise your hand. And I have there now, and I wasn't watching to see who in first, but I know that Representative Cadena needs to jump off early. If she is still on, we'll let her go first. Representative Cadena, are you on, or did you have to?
Yes, thank you.
Okay.
Just in time, Chair.
Okay.
Hello, and thank you, Chair. Thank you, Pam, for letting me sneak in before I have to run back to parenting. I just want to appreciate the really thoughtful conversation and presentation. As it happens, Angela Fritz is my northern neighbor here on my irrigation ditch. I can see her just across the road and up the irrigation ditch. And in the room that I've had to learn from Angela and the other CNRs, the other folks here in Las Cruces and other spaces, I think they are presenting information that's clear and compelling and articulate, and especially when we think about the kind of healthcare access we need in rural and frontier communities. I'm certainly paying attention to the asks they're making and think it's something that needs serious consideration So I just, again, thought that this is the right time to have these more nuanced conversations, and look forward to the questions that come as I listen in. Thank you, Madam Chair, for letting me sneak in.
Thank you. Thank you, Representative. Senator O'Neill. And after Senator O'Neill, I have Representative Ferrari.
Hi, can you hear me?
Yes, we can hear you.
So, thank you, Madam Chair. And Madam Chair, can I ask if Co-Chair Senator Ortiz-Pino is on this call?
He is.
Okay, so, all righty, because I am going to speak now as a former member of the Senate Public Affairs Committee, otherwise known as the Scope of Practice Committee. And Senator Ortiz-Pino will know exactly what I'm talking about. And thank you, the three of you, for your presentations. But am I not correct in assuming that this same bill was introduced not last session because it didn't get a message, but in the session before, or a very similar bill?
Which bill are you speaking of? We don't have anything sponsored right now.
You know, it's really hard. You have to understand lay people, and to if I was in your shoes, I would never say this is not a scope of practice bill, because it is a scope of practice bill. It draws a lot of opposition. I remember 2 years ago in our committee, the anesthesiologists were hardly enthused about the proposed CRNA, bill that was before us, and it went down. So the notion that it isn't a scope of practice bill, just please do us a favor, even if you know to your core it's not in your eyes it's not, it is in our eyes, because that's what we have to do as lay people, sort out these internecine turf battles, okay? So my question is, have you seriously consulted with the anesthesiologist about this legislative initiative? The anesthesiologist who opposed this vehemently 2 years ago.
Mr. Chairman, I answer the question?
Yes.
Okay.
Yes, go ahead.
Okay, great. Thank you so much. So this will not change the way CRNAs practice. Whether you vote yes, whether you vote no, we go back to work on Monday and nothing changes.
Yes. Was this bill introduced, excuse me, was this bill introduced 2 years ago?
A similar bill was.
Yeah,
and
very similar, very similar.
If I may, please, it was a combination bill, and we had a lot of support for our portion of the bill, but because the other component of the bill relating to the Board of Nursing was opposed, that was ultimately the reason for the demise. We have not spoken to the anesthesiologists, the physicians about this. This is an update in the Nurse Practice Act. It will affect the nursing language.
So,
This should
Madam Chair,
not be more their practice.
time is limited here. I would urge you to talk to the other half that opposed this. I mean, seriously, it is a scope of practice bill, and also to the anesthesiologist. If you want this to pass and not repeat, I don't think I've had a session where there isn't some CRNA sponsored bill, around this, and it always runs into the same problem. So we want you to flourish in your professions. I love the work you do. Without it, where would we be? And we want to help. I mean, totally. But don't tell me it's not a scope of practice bill, if nothing else. But I'll see it in judiciary if you get this back. So anyway, that's all I have. Other than, when you're doing the history of an initiative, try to include the most recent history. Like there was much talk about under Gary Johnson and this and that, but a lot of us are familiar with the fine work you do. You can assume that we know the wonderful work you do. So you can kind of keep that in mind and kind of get to the point and really anticipate. I mean, I want you to get what you want. I do. But please talk to the folks that are going to oppose this before you come into committee. That's all I have to say, Madam Chair. Thank you.
Thank you, Senator. Next, we have Representative Ferrari.
Thank you, Madam Chair. And this is directed to Gloria and Ms. Doherty, as you were mentioning about the hospital parity bill, HB 280, and myself and Representative Cadena were the sponsors, the proud sponsors. And when it was to go into effect this July, and checking with some of the hospitals, we found out that our own Memorial Medical was not complying, and we sent a letter, saying we really need you to adopt these rules and make it so that midwives and nurse practitioners could have the admitting and discharge privileges, which are so important for the continuity of care for your patients. And so what I think the contention is that they don't have to comply providing that for Medicare patients when the CDC has already changed their rules for Medicare patients to be able to have the continuity of care from their nurse practitioners and midwives. So when you were talking about, well, we might need to do something in the legislature, in the next session to change this bill, is it to clarify that, or can we just continue trying to fix that before the session?
Madam Chair, Linda Siegel.
Hi, Linda.
Go ahead, Linda.
I can take that question. I think that we may need some clarifying language and a little bit more explicit language. That's what we're thinking about in the bill to address exactly the steps the hospital is supposed to take. As it turns out, the Medicare piece, that ultimately a physician must be must sign off on certain types of Medicare. And what the CARES Act did was it suspended that requirement that there be a physician, quote, involved. And we know the involved means nothing except they signed a document for a patient they've never seen. So we, national associations, are working, of course, on trying to extend that CARES Act provision so that we, once and for all, can resolve these issues. I think in New Mexico we may need to do a little tweaking.
Great. Okay. I wasn't sure if it was just more of a matter of explaining it or if we really do have to, Madam Chair, Linda Siegel, to make sure that we do need to do it legislatively. So thank you. I appreciate knowing that and hope to help with that too. Thank you, Madam Chair. That's all.
Thank you. And before we go on to the next committee member, I did fail to recognize Sasha Poole from the Board of Nursing. You're presenting today, but are here for questions. Do you want to add anything to the conversation, Sasha, before we, any comments that you might have or clarifying information?
Madam Chair, this is Representative Thompson, and I just wanted to follow up just a teeny bit on Representative Ferrari's, what she had to say. So here, Sasha has something, and then.
Yeah. Do you want to go ahead and finish up your thought since it was related to, and then we'll go to Sasha?
So I was so excited, Madam Chair, to have been involved in passing for the physician's assistants to have autonomous practice. And the first physician's assistant I saw after that, and it had been months, I asked her how it was working, and she said, what? And so I explained it to her, and she said, well, oh, our system makes docs sign off for us. So even though we had passed more autonomous, the billing system, it was Loveless at the time. She said they don't allow us to practice autonomously. So I think that's something we need to kind of keep in the back of our minds, that just because we practice something, particularly some of these huge healthcare systems may not it may not go along with their rules. So just passing a bill doesn't ensure that the practitioners benefit from that. So thank you, Madam Chair.
Thank you. Thank you for that. Sasha, are you there? And do you want to make any comments? I see you unmuted, but I don't hear you. And Sasha,
Madam Chair?
Oh, there you go.
Okay, thank you. Sorry about that.
That's all right.
My name is Sasha Poole, and I'm the Executive Director of the New Mexico Board of Nursing. My primary purpose for being here today is to support the Certified Registered Nurse Anesthetists, the CRNAs, in their request for independent practice, both as written in law and as they actually practice each day. This support is also being provided by the Board of Nursing itself. So this is not just something that the agency is standing behind. This is something that the board has authorized me to express their support for this amendment to the Nursing Practice Act. I would like to clarify a couple of items about the nurse practitioner from the Nurse Practitioner Council about the APRN compact. The primary, most concerning thing was just, I think, a misspeak. There was the introduction of a number of hours of practice that an advanced practice registered nurse must have before they would be eligible for a multi-state license under the APRN compact. But those are not hours that are being required, supervision or anything like that. These are just hours of practice. And it's 2,080 hours, which is pretty average for states that have transitioned to practice requirements in their law. That's a pretty average number. So you do not, that is not to say that if New Mexico were to enter the compact, that nurses in New Mexico, APRNs in New Mexico would lose their independent practice. They would simply not be eligible as brand new advanced practice registered nurses to have an compact multi-state APRN license until they would hold until they've completed the hours of practice. It's not supervisory hours, it's just simply practice hours. And the second thing is sort of two-pronged. The commission doesn't own licensing data. The boards of nursing own licensing data. This is not unlike the Nurse Licensure Compact, where we do share data, but we are the owners of the data as the independent party states. So if there's an error in the data or whatever, it's up to each board to make those corrections. And the third one is, I know that there are concerns about finances. I do not think that the New Mexico Board of Nursing would have that much of a financial hit for multiple reasons. Somebody could come to New Mexico on a compact license, could fall in love with the state and decide to move here permanently. Upon deciding to make New Mexico their new residence, they would be required to obtain a license from the New Mexico Board of Nursing. So I think that we would still receive revenue from nurses coming into the state, APRNs coming into the state. It's not quite as frequently as, not quite as early in the process as we currently do. We are already at the statutory cap for the renewal fee, and so we would not be able to increase licensure fees to to APRNs or nurses without legislative action. And at this point in time, I have no interest in requesting for an increase in statutory caps on licensing fees. I think that they are adequate just as they are. And with that, I stand for questions.
Thank you. Thank you, Sasha, for being here and for clarifying that. Do we have other questions from any committee members? I have a few. Just checking my list. Raise your hand if you have a question. Oh, Senator Ortiz-Pino, Mr. Chair, go ahead.
Thank you, Madam Chairman, and thank you for the presentation. I just wanted to try to clarify a couple of things. Out of all the issues that got raised here during this presentation, it really boils down to the attempt at removing the antiquated requirements around the formulary that you're seeking. Am I right about that? The rest was covered in another bill, but may not be being fully implemented by some of the hospitals. But there's no need for further legislative action on that piece. It's just that antiquated formulary language. And was there something else, Gloria, that I missed?
Yes, thank you, Mr. Chair. For adding dispensing, that was also a compromise back in the 90s that was kept out of our Practice Act to get the independent practice.
For adding which? I'm sorry.
The word dispense. D-I-S-P-E-N-S-E.
To dispensing medication.
Dispense. Okay, yeah, dispense.
Yeah.
And in fact, you're doing that now. Is that right, Madam Chairman? Yeah.
Yes, Mr. Chair. The psychiatric nurse practitioners are doing that regularly, as well as some of our rural practitioners.
Now, have we ever had these two topics brought to us before? I don't really remember them that way.
No, Mr. Chair, not since my involvement in 1999.
Okay, so I think Senator O'Neill may have been reacting to a different piece of legislation that came before us a couple of years ago. This one is pretty cut and dried, as I understand it. Is somebody preparing it for introduction?
Mr. Chair, I defer to Linda Siegel for that question.
I'm sorry, Mr. Chair, what was the question?
Madam Chairman and Linda, the question is, do you already have somebody working on a piece of legislation?
We will be doing legislation, yes, for the pieces that the nurse practitioners are talking about.
That covers those 2 points that Gloria was talking about?
Yes.
And are you seeking a committee endorsement?
Not necessarily, because we don't really have the bill drafted.
Well, I mean, we won't be endorsing until November.
Okay, well, yes, we would seek endorsement.
Okay, well then we'll take a look at it then. But I just wanted to clarify, of all the issues that got raised and things about extra hours and so on, it's just these are the only two you're seeking some legislative action on, really, right? The antiquated formulary, removing that, and then permitting dispensing.
Yes, Mr. Chair.
Okay, thank you very much, Madam Chairman.
Thank you. And separately, the nurse anesthetist, which are also an advanced practice nurse, is seeking to, and I know Senator O'Neill said this was a scope of practice issue because there was opposition in the past. It is technically scope of practice. However, I just want to clarify its current practice and has been for 18 years under what's essentially an executive order, instead of having it in statute. And so that's old back under Governor Johnson, but it has been existing for 18 years in their ability to to practice independently. It's a supervision issue. So technically that might be a scope of practice, what you can do with or without supervision, but it would be putting in statute what is currently allowed in current practice over the last 18 years for independence and not requiring supervision. So that's a separate issue specific to the nurse anesthetist. Do I have that correct, Shannon and or Angela?
Yes, Madam Chair, and thank you so much for those words. And I just wanted to remind everyone too that all hospitals have a choice of what model of anesthesia they want. They choose CRNAs, they choose physician, or they choose a combination. And this bill will not change that. Everyone still has their own choice. And I want to extend the invitation for all of you to get to know us better before this comes up in the session. We're willing to have phone calls, meetings, Zooms, and answer questions and meet with you all that you need to make sure that you're well prepared to make an informed decision when the time is right. So thank you.
Thank you. Thank you. And then let's see. I just wanted to clarify also that the advanced practice nurse or nurse practitioner compact, they are not included in the compact now. So the nursing compact now excludes advanced practice nurses. Is that correct?
Yes, Madam Chair. There are RN license piece because we have to maintain both licenses,
right.
RN and the advanced practice. So as an RN, we can opt into multi-state licensure, but as a nurse practitioner, it is not a consideration. And as far as I know, there is no legislation being planned, but just wanted to let you know our stand on it.
Okay, great. Great. That's helpful to know that. It does point out, however, there's a great one compact is not a compact broadly. It seems there is significant differences between different compacts. For instance, the psychologist compact is all about telehealth. It's not about physically relocating and practicing in a state. It's about providing services interstate by telehealth. So it's totally different. And each compact entity has its own commission overseeing that compact and may operate, as you pointed out, a little differently. I just want to give kudos to all the advanced practice nurses and the nurse practitioners for leading the way. New Mexico led the way as the first state, and it's something to be proud of. And lots of states are catching up, but as you pointed out, that's the problem with the compact potentially, is that many of those states haven't been doing it to the level we've been doing it here for a long time. And as far as privileges and what you can and can't do, whether it's ordering hospice or admitting and managing someone in a nursing home, a lot of that is also dictated by federal law, not the state law, even though you're fully licensed to do that here. And that's a payment issue under Medicare, or because most states didn't allow it. So we were a unique state, and that's gradually changing. I think now you can admit to hospice, correct? And so those are changing as more than half the states. So did I have that wrong?
Yes, Madam Chair. Actually, even with the CARES Act that came through, we still are unable to admit to hospice so we can bill and follow them throughout. We can do home health care, though. And
oh, okay. So that's a change. That's a change. Okay, I had part of it right. And what about nursing homes?
I believe that it is still a physician we can admit, but a physician has to see the person, the resident, within 72 hours.
Yeah. Okay.
But it doesn't exist for hospitals, oddly enough, that we can do the admission. It's after there's a specific length of stay that's somewhere between 14 and 21 days that a physician has to see the patient.
Okay. Good clarification, but just for the committee and public to know, that's dictated by federal law and not reflective of our state law and requirements limiting what advanced practice nurses can do. So again, thank you for being such a good model. I personally have gotten most of my care for many, many years, either by a nurse practitioner or PA. And as I, just a side note, as I reintroduce my legislation this coming year for end-of-life care, have included again, will include again the ability for at least one of the practitioners who sees the patient and affirms terminal illness, and as well as whoever prescribes, can be a nurse practitioner or PA. Because that is for much of the state where the access is and the kind of provider that people see and who serve as their primary care provider and who has the relationship with that individual. And so just like with the nurse anesthetist, and many communities don't have physician anesthesiologist, there are communities that don't have a physician but have nurse practitioner or PA. So thank you for all the work that you do. I just, as a point of personal privilege, Mr. Chair, I just want to tell people I'm working from my bed, as you can see in my picture, because my daughter's doing nursing school in the other room. So she gets the prime spot, and I'm relocated to working from my bed. So so that's why I'm where I'm at. But very proud of her that she's pursuing and wants to be a nurse practitioner. That's her goal, to do primary care. So I'm trying to raise them up right. So thank you. Anyone else with any questions? Seeing.
Madam Chair?
Yes, go ahead.
It's just fitting. We don't get paid and we get kicked out of the prime spots in our own house. Thank you, Madam Chair.
Madam Chair, can I, Senator O'Neill here, just to respond? I might not be as confused as you both think I am. I understand that was a different bill. My apologies for that. But my point to these fine advocates is, if you don't want it to be a heated scope of practice kind of committee, by all means, talk to the anesthesiologist. I have anesthesiologists in my district and in your district too, Madam Chair. And I am hearing rumblings about this bill. So educate us. Okay, so that's my point. And I'm sorry, you know, one of my colleagues teased me that it's PTSD from previous meetings. You know, we had some real doozies in SPAC, and I promise you, I will come in there with a objective. I will forget the past, and you know, I'm just reacting to old, very, very unfortunate, very heated, you know, things that we don't have to go through if people really understand what the bill is and what it isn't. That's all I'm saying. So I'm not that confused. Okay?
Thank you, Senator. And I echo your advice. Absolutely. And we've had many actual real complex and substantive scope of practice bills in the past where it's taken many, many years to get it done because the parties don't come together. Even dental therapist is actually a really good one. We finally, I think, legislated that they come together, at least gave pretty, I think did a memorial probably to actually have all the parties come together. And it still took us a couple of years to work out the scope of practice issues. So that's good advice for any bill. Meet with the opposition and get them to understand and you may not ever come to full agreement, but then you understand what the issues are and can fully explain your position as contrasted from the opposition. So excellent advice. I echo that strongly. Anyone else? Any last comments?
Madam Chairman,
Yes.
During the public comment, I had asked if Carla Flowers were present.
Oh.
She had to step out. I think she's back. If she is, this would be an opportunity for her to give us a public comment on some issue.
Great. Nancy, can you check that and let her in?
Yeah, she is currently unmuted.
Okay.
Carla, did you?
Are you there?
Yes, we can hear you. Go ahead.
Okay. All right. You may recognize my name, and I want to thank everyone for allowing me to speak. There were great presentations today, and I love to hear the talk about mental health. This is a topic very close to me. My daughter is currently in prison. She was in an abusive relationship before, during, and after her marriage, which resulted in 4 major mental health illnesses. She sought help, but timeliness was a concern, and she was having a hard time getting help. And this is what contributed greatly to her being sent to prison. And I was here when Zach Herman was talking about, I think it was the modeling, I'm not sure, but he said the process could take up to 2 years. 2 years is a long time when you have a mental health issue. And I was glad to hear that a lot of the emergency things kicked in when the pandemic began and is still in. But we need to focus on mental health all the time. It shouldn't take a pandemic for mental health to receive the focus it needs. And it definitely shouldn't take someone going to prison to get the mental health care that they need. She is currently taking medication and is 180 out from where she was. So she is getting help now, but it took going to prison for that to happen. And her abuser is raising her children. So I think we really need to look at the mental health aspects in everything we do. Thank you.
Thank you very much, Carla. We'll keep that in mind. And members, unless there's anything else, this concludes our agenda for the day. I would remind you that we meet again next Thursday, the 24th and the 25th, and that tomorrow there's a Disability Concerns Committee meeting. And so happy Zooming, everyone, or happy Cisco WebExing, whatever it is. And hope to see you, if not tomorrow, then next week. So long. Thank you, staff, for putting together a terrific group of panels.
Thank you. This was great today.
Thank you, Mr. Chairman and Madam Chairman. Senator Rodriguez.
Thanks, everyone. We'll see you tomorrow, hopefully.
Thank you. See everyone. Bye-bye.